So from this, it's just basically gonna explain the role of everybody that's in the pharmacy role in terms of pharmacists, the CEO, and everything like that. So from the pharmacist over here, you know, the most important thing is understanding that our assignment is done by NAVMED. So just understand that if you see a question of who does the pharmacy assignment, who determines how many people they have, NAVMED's the one who actually makes the determination for us. You know, if you are in an employee setting, sometimes you don't have a pharmacist, so sometimes you can just be the only pharmacy tech on that ship. You're not necessarily gonna have a pharmacist. So if you see something like that when you go operation or anything like that, something that happens, but that doesn't mean you're not gonna get your med. There's things in place that we're gonna cover down and who can act as one of the pharmacists. Alright, these are the CEO's responsibilities when it comes to what they need to do for pharmacy. And this is where the part that I said you don't necessarily need to have a pharmacist to be that. You can have a senior medical officer be the one looking at your prescriptions, so that's why you need to have a commissioned officer at least in charge of pharmacy. They don't have to be working in pharmacy, but ultimately they're responsible because it's under their umbrella. So not necessarily a pharmacist, but more than likely it's gonna be the senior medical officer. These are the list of responsibilities of what we're supposed to do when it comes to what we do for the command. You know, the most important of this is just basically updating policy. Make sure we do the inspections, because that's why we see us going to your wards. If you work here at the hospital, you see that we have to do a clinic inspections. That's part of us, because we need to make sure that you're taking expired meds and everything that you need to do, and you're actually not preparing meds on your counter that you're having lunch. You know, stuff like that, you're gonna see that we have to maintain that order. So it's not that we wanna tell you how to run your area, but there's certain codes that need to be established. And the last thing is just basically maintaining the MTF formulary, because it changes a lot, so we have to make sure that we give up to date and what you guys are able and able not to prescribe. A lot of changes are going out with DHA. There's a lot of stuff that's changing out of that formulary. So if it's something that you got in the past, the reason why you probably no longer get it, especially if it's an OTC, is because they changed our formulary, so we can no longer dispense it. You know, they don't want to spend money on it, so we can't dispense it anymore. And that's why the changes are. And if we don't stay up to date, we're basically breaking the rules. So unit dose system. The most important part of this is basically to kind of self-explanatory. You give one drug at a time. So in my pharmacy, I have a machine that we actually take a bottle of 500 and split it into 500 individual tablets in a little packet. It's very fun to do, so if you want to see it, you know, by all means, come and join me. But the most important thing is that we will never dispense any more than 24 hours. So every 24 hours, regardless if this patient's here for 30 days straight, we gotta redo the whole med. I can't give them 30 days worth of meds. I always have to be a 24-hour interval. So understand that for a unit dose system, anything that is dispensed in an inpatient setting, I will not give you more than 24 hours. So that's the key point of that, that's why it's highlighted. This goes more into depth on how do we do our contracting. Normally you don't see this question is pharmacy related. The only question that I see that is pharmacy related when it comes to the system, most of us use demos in the medical settings, so that's the system that we use to make our medication orders as well. So that's the important part of when it comes to pharmacy purchasing. Therapeutic committee. This is very important because I've seen a question at least in one or two of my tests. This is basically who set up our rules of engagement. You know, they meet quarterly, and that's one of the things that you have to understand. It's not just pharmacy. There's a lot of stakeholders in the medical field that they're gonna sit down and determine, hey, what can we carry? What shouldn't we carry? What's too expensive? What is something that we just have just for show? So that's where the pharmacy and therapeutic committee comes in. We have one here at the hospital, and the members either we have to have medical, nursing, risk management, and pharmacy. And these are basically the functions of what they do for us. But overall, it's basically it comes down to they set up our rules of engagement when it comes to pharmacy operations. So over here it gives you an example of who could be prescribers. You know, medical dental officers, civilian pharmacists, they can be done as well. You know, it's just a matter of understanding the roles, like IDCs are able to prescribe, but they have a formulary that they have to follow. So there's certain prescriptions that IDC shouldn't follow. That's why we said we have to maintain formularies, because this gets sent out to the IDCs at the waterfront. And if I see something that shouldn't be prescribed, we're always gonna kick it back. There's also medication that requires a co-signature from a medical officer. So if we kick something back, do not take it personally. It's just the IDCs, yes, they do a lot for us, but they're also restricted within their certain areas of why they have to stick for formularies. Outpatient prescription, we covered that in the last presentation. We said there was the DD 1289 for single prescription use, but for multiple prescription use, the NAVMED 6710-6. That's the one that she was asking about. It's basically like that's it looks like a little spreadsheet, and then you have a list of medications that you have used. It's just basically something that you will put like on your binder, and that's the only way we can take more than one prescription. Otherwise, if your provider's not willing to give you that and they don't have access to that, they just have to give you a hard copy for every single medication, and we love those. But again, most of them they need to have, we have to be clearly able to understand what is written. We can't assume that those are the instructions. So make sure all the components that we discussed on the last slide are there. The date of birth needs to be over there. If it's a PEDS patient, we need their weight, because the importance of understanding their weight is that we need to do their dose weight based. So that's why we need the PEDS patient's weight. The age has to be there too in order for us to determine that, but their weight is very important, otherwise we have to call a doctor. So every single thing is in there. If you said that you're gonna get a refill and the doctor didn't write it, I can't give you a refill. So understand that all of that needs to be done in the initial prescription. So this goes over how do your bio should look. It looks like a lot of information, but it basically comes down to having your name on it, prescription number so you can reference when you need a refill. The date that we fill it, because prescriptions are only good for a year, so if you get something that's gonna have a year's supply worth of that, I'm only gonna be able to give you 3 months, but I need to be able to count a year from the initial fill, because anything after that, regardless if you have a refill or not, if you haven't done it, it's gonna expire. So I cannot dispense it after that. That's the reason why we have the date of fill in there, in order for us to understand that it's only good for a year. Prescriber's name, it has to have my initials and whoever the pharmacist check it, because we're saying that we took our time to make sure you got the right medication. Most of these things are automated unless like you're on a ship. You're gonna see that written by hand, but most of the things are done automated, but every single one of us has a code that links to our initials, so we know exactly the process. It's not like the machine just verifies and everything. We do take our time. That's why when you come to my pharmacy, sometimes it takes a little bit longer, because we have to take our time to do that. And it will also tell you basically don't use it beyond this day. That's not every single medication will do it, because some medication will not expire on you, but if you're using any kind of suspension for your children or for yourself, if you don't able to take tablets, do not take it after it expired, because you shouldn't take it. That's the reason why it has to be used date. And the cautionary labels is basically if you're pregnant, you shouldn't be taking medication. If it's gonna cause you dizziness, the medication should label it. All of that should be in the system for you to understand what kind of information you need when you take a particular medication. So for here, it's just basically more into what the MTFs are able to do and not to do. It's just more of, I'm not taking any prescriptions over the phone. I can take a verbal order when I'm in an inpatient setting, but I'm expecting that order within the next 30 minutes that the doctor's gonna write it. Because sometimes we do emergency situations, and we understand that the doctor's not right there in the computer. We can take those verbal orders, but only a pharmacist is able to enter that order, and we have to verify within 30 minutes. So understand that if you call me to the pharmacy, I need meds, unless I see a doctor prescribing it, you're not getting that. We also, the only way we send prescriptions during the mail is if we use Express Scripts, so I will never mail something from my pharmacy. That's a separate entity from us, so you're never gonna see anything mail out of us. The only option that we have for pickup is just the refill sites, but it's not necessarily mail. You do have to go and pick it up.
No, the MTS can't, but what program does do mail pharmacy? TRICARE. right? So just know that that's the difference. TRICARE, through TRICARE, you can do a mail pharmacy, but the MTFs alone can't be doing that to you or mailing that to you.
This is something that I've seen in other MTFs, the OTC program over here at OTC enforcement, we don't have it. So a lot of people come around asking for co-packs because they're used to that. We don't longer have that, so we don't have that medication available for you. You can't just walk into a pharmacy anymore and ask for, hey, I'm having a cold, can you help me out? Can't do that anymore. No, we used to do that back in the day, but we can't do that anymore because the program is not established. So
They do it on the phone a lot. On carriers, they do it a lot.
yeah, but for us, since we're a little restricted, it's just because for our system is a little more trackable since it's not established in place. I can't, like, our inventory will match what we're given, so and carriers is normally on paper, so that's why I said NTFs. The carriers are not necessarily falling under NTF's umbrella, so that's the reason why they have a little more leeway when it comes to what they can and can't do. So this is basically, it's just limited to how much of the medication we can dispense. We can dispense up to 30 days of a controlled substance. It's just one of those things that, depending on the doctor write it, we don't want it to have too much. A lot of things, we have to take into consideration when we're filling this because, you can get addicted to that. You can start refilling it early. So sometimes you're gonna put a pause into that, and we're able to tell if you're coming in too early. A day or two is okay, but you shouldn't be coming through half the month after you got a 30-day supply, asking for another 30-day supply, because something's going on. Like I said, be careful with the dates with the prescriptions, because we need to fill the Schedule 2s within 30 days of the original date. So that's why if there's anything over than that, we're not gonna take it. So that's what I said, be careful with those dates as you look in the prescription. That's why the date's very important, because if I'm not able to tell, I'm not gonna give you your medication. There's always exceptions that can do depending on, federal or state laws. So there's a lot, depending on where you're stationed, they might be able to do it, but it's also under the pharmacist's discretion as well. So it's not guaranteed that because that's a state law, the pharmacist will put a license to put that on it. So the pharmacist has the judgment whether they want to give it away or not. The most important thing about the Schedule 2s is that these do not have a refill, so every time that you need it, you're gonna get a new prescription. So understand that Schedule 2s will never have a refill written on it. So if you see that, and even for yourself, you understand that prescription was written wrong, so that refills, you automatically lose it, you gotta go to the doctor. These are not allowed to be refillable. The rest of the stuff, the Schedule 3 to 5, those are the ones that you can refill within 6 months. That's what I said, depending on the date. If it's been less than 6 months, I can refill those for you. Anything longer than that, for 3 to 5 only, just remember that, 3 to 5 are the ones 6 months. Schedule 2s, they only do 30 days. That's the difference between the two.
This slide right here is what will be on the test a lot. So know how many times they can be filled, know the time frame, and know the supply, or how many days for deploying members, right? So the easy way to remember the Schedule 2 through 5 is 6 months is how many days? 180. So if they can be filled within 6 months, your deploying members also receive up to 180-day supply of Class 3 through 5, right? And then both of them have 100-day supplies, your Class Schedule 2 and your Schedule 3 through 5, where they cannot exceed a 100-day supply of these drugs.
In any instances that your deployment might be extended or it's a little bit longer than that, there's programs out there that can the fleet actually have programs that we can deliver the medication to you, but you will never get anything than 180 days for what's called control medications. Understand that we're not trying to be mean to you, we understand people deploy for longer than that, but that's the maximum we're allowed to dispense. For non-controlled substance, this is what I was talking about, that some of them are good for a year. So if you hold a prescription for a year, not everybody does that, but our elderly, they can't, sometimes they're by themselves, they can't keep track of what prescriptions they have, they get a lot of them at once. So as long as they bring it within the day before that year expires, that prescription is good, they probably forfeit the rest of the refills, but they have until that day in order for me to be able to fill that prescription for them. Anything after that, we can't do anything. We probably be able to do an emergency supply depending on what it is, but if anything's more than a year, we can't put it. So remember that for non-controls, you have up to a year from the day it was written, in order for us to be able to, fill it. And we can only dispense it to 100-day supplies. 9 times out of 10, we only dispense 90. 100-day supplies, normally we do it like, for example, multivitamins or prenatal vitamins, stuff like that. But 9 times out of 10, we try to stick to the 90-day regimen, and most providers don't write a 100-day supply anyway. The only things that you may see as something that you will refill sooner than 2-3 months is the ones that are PRN. Normally there will be 30-day supply with 11 refills. You know, if you want to do it the easy way, get your doctor to write it 3-month intervals, because it's easier for you to pick up instead of having to wait pharmacy every 3 months. But that's what PRN means. Is basically they cover the entire year, but you have to refill it more often. So basically every 25 days you're gonna refill your medication. So you don't have to necessarily be in pharmacy, and this is what I was trying to do. You don't necessarily have to be in pharmacy or a pharmacy technician in order to dispense medication, as long as you have to have a prescriber. So that's one of the things is like when we go to deployment settings, when we go to med sites, you know, not all of us were pharmacists. We have other people that were able to dispense the medication. As long as one of them, the approved prescribers, were able to get their hands on it and actually sign on it, anybody can give it out. We just need to actually make sure that that authorized prescriber, what's in there, and they actually said, hey, I signed for this medication. But they don't necessarily have to be the one giving it out, because my pharmacists normally don't give out the medication. The pharmacy technicians do. So understanding that they're not restricted to that when it comes to dispensing medications. And again, you know, everything that we do is reviewed by the PMT committee. That's basically the abbreviation for the Pharmacy and Therapeutics Committee. So you're gonna see the PMT committee a lot, especially in the corporate community. You're gonna see it a lot when you go to meetings, when it comes to making decisions, how do we move forward. They're the ones who are gonna determine, especially pharmacy related stuff. And they're gonna inspect basically that we're using all the guidelines, like for example, PICSs. We need to make sure we scan everything that we put into those PICS machines, you know, that's a safety measure. If we're bypassing that and they run a report, we get in trouble because we shouldn't bypass that, because that's potentially we can kill a patient by bypassing that. You know, dispensing the right amount of medication, dispensing only authorized stuff on a ward, like for dental clinic. Dental has an authorized list that they have to be dispensed to them, because basically they're allowed to use that. If I dispense anything over that and somebody finds it out during the inspection, we get penalized because we issued that to dental without the PMT committee actually verifying that that's something that we can actually give them. So if it's something that your providers like, but they haven't actually write a request to the PMT committee, I probably won't be able to give it to you. So, you know, so the provider that, they might have to look for alternatives within the options that we have. So these are the people who are actually able to go in through our files, because you know, we do keep our files, we do keep 2 years worth of information when it comes to prescriptions. So only this authorized personnel is able to do their investigation for us. You know, it's, nobody can walk into my pharmacy unless they're actually authorized for that, to do an audit and be like, hey, I wanna see your prescription. You know, we limit it to those people, because obviously this is private information, we have everybody's information in there. So those are the only authorized members that are able to do that when it comes to that. For this, one of the important things is like understanding where refills are gonna be able to be able to call in. So 75% of your medication, you know, you don't have to wait until you're in the last pill to call it in. More than likely, it's not gonna be a test question. That's just basically information there, so you guys understand the pharmacy operation. But it is for you guys to understand that, hey, 75% is when you can actually do it for that. Also, if my system has downtime, the only thing that we can take hard copy prescriptions is for by civilians and MTS provider, but we're only probably gonna limit it to urgent prescriptions like payments, antibiotics. You know, if you're having any kind of blood pressure issues, any kind of other issues, you probably have to come back when actually regular business time our system is up. So if you get hard copy, system is down, we're normally limited to that, because there's only so much we can process at a time when our system is down. Inpatient dispensing. This is basically what I do in the hospital, because I'm an inpatient tech. You know, we are in charge of all inspecting all the wards and all the areas to make sure they're keeping everything, not just the Pyxis machine, but any area that you prepare medication. If you have, for example, the OR, if you have 20 ORs, I have to go through every single one of those 20 machines and inspect every single one of the medication areas on a monthly basis. So, judging on our manpower, that can take a lot of time, but that doesn't mean I gotta stop doing it just because I don't have the manpower. I just have to make sure that I inspect it on a monthly basis, so you guys understand that this is what we do for pharmacy. Everything that's related to pharmacy inspections, we do it on a monthly basis.
Except the quarterly meetings with P&T.
So this is more information when it comes to our supply and our stock levels. Anything that we have in our pharmacy, it should last like at least 30 days. Most medications will burn through longer than the other. There's a lot of manufacturer unavailable things. So that rule is not like, it is something that we should follow, but sometimes if we're not able to get it, we're not gonna get penalized for something that is not available on the market. We, at the end of each year, we can do an annual inventory of all the drugs, to make sure that we dispense everything we need to dispense. For the controlled substance, we do, the CSIB, and they'll come in at shorter intervals to make sure we actually do what we're supposed to do. And they see we have a lot of discrepancies and something that we cannot explain, we actually get investigated, and that's why they're making sure they're keeping us honest, and our medications are not disappearing on the same. The important thing from this one is that you should remove anything that expired within 30 days, so you shouldn't be finding anything on your Pyxis that expired within the same month. The only exceptions to that is, like, for example, epidurals, pitocins. Those are short dated, and we have a list of those. So if you see an epidural that's gonna expire within the same month, don't go ahead and pull it out because it's still good. Those are shorted, they're only good for a week, but those items are authorized to be in your actual Pyxis machine. So if you see something like that, don't freak out. We're talking about general meds, stuff like that, short stability. It can be there when it's about to expire. Obviously, if it's expired, don't leave it there. Don't give it to the patient. But if it's a day from expiring, it's good until that very last day. We're probably not gonna pull it because basically we're wasting ours.
Same concept for your supply too. So if you have something in your normal supply that says August 2023, it's good until that last day of that month.
So from this slide, basically the most important thing is just understanding how multi-dose vials work. We got a lot of patients that, like insulins, we can use it for 28 days, but also we gotta make sure that we're using a septic technique when it comes to this. Understanding the difference between that and a single dose vial. You shouldn't use a single dose vial more than once, because they're designed, the multi-dose vial probably has preservatives, so you can poke it more than once. The single dose vial does not have that, so you probably, if you keep using it more than once, you're probably gonna get the patient to contract an infection if you're actually using it for multiple patients. So understanding the difference between the two, most of these are labeled by us, but if you open it on the ward and do it yourself, the insulins, we put it ourselves before you guys even open it, but other vials that you may be using, understanding and reading that it's a multi-dose vials can only be good for 28 days. So make sure it's very important for patient care settings. So this is just more information into what governs the controlled substances. It's basically the Act of 1970, that just like we covered on the previous slide. Pharmacy is very repetitive when it comes to the slide, so it's basically the same information going over and over and over. Like I said, Schedule 2s, we not use those. We're not allowed to carry those on site. So you shouldn't see a Schedule 1, like you shouldn't be walking into a pharmacy and seeing heroin because there's something wrong. So something like that. Schedule 2s, we're gonna carry over there. Yes, we do carry cocaine, but it's very limited, so it's not, it's very special cases for it, but it's not like we're gonna be a massive loader, there's just little vials of 4%.
Pablo Escobar in this bitch over here.
And alcoholic beverage, we do have a gidunk, but we don't keep alcoholic beverages in pharmacy, so we shouldn't have finding alcohol in the alcohol packs. So if you see beer in pharmacy when you walk into expecting somebody doing something wrong.
But they do kind of have that though, don't they? For like certain patients.
But, okay, so over here is basically the storage of the controlled substances. Basically everything that we do controlled substances, I can't just leave it hang it on the counter. So make sure we actually have it doesn't necessarily have to be a big bolt, but it has to be something that I'll be able to lock. So Pyxis machines that we have in the pharmacy, they require fingerprints, so we know exactly who pulls stuff out of it. So that counts as a storage machine. Doesn't necessarily have to be something that you lock with a steel lock or anything like that. It's something you can actually lock for the night and nobody's ever has access to it other than authorized personnel. You know, there's only a few people that have the combination to it, and normally we put this combination when they come and change, we put it on an envelope. I don't even get the combination for that. Only my commission officers are able to have that, and the CO keeps a copy. The important thing of this is we have to change it every 6 months. So if you get a question about when do we change the locks for controlled substances, it's every 6 months we have to change that, you know. But like I said, not even pharmacy department other than the commission officers are able to have that code in order to open our vault.
Pay attention to what it's talking about on the storage, right? Vault or safe is for Schedule 1 and 2, and then your locked cabinet security is for 3 through 5. I know that'll probably mix you up on the test, right? And then, as I've seen it before, that combination on the periodicity of it being changed for the combination is usually popping up on there also. Sealed envelope, and it has to be changed every 6 months.
So understanding the difference between the two, understanding that we have to make sure we do our quarterly audit in order to determine. That's what CSIB does for us. They come in quarterly, they just have to inspect our stuff and make sure we don't have any kind of potential abuse going on based on the stuff that we're dispensing. Now, this is more of who has custodial security of everything that we have in pharmacy. You know, it's just one of those things that basically shouldn't be dispensing more than 3 days for a 3 to 5 on a stock level on the area. So if I put something in fixes, you know, I should put a limited amount of drug for you guys to be able to treat that patient, but that's not gonna sit there like insane amount of drugs, even in your locked cabinet. Even when we go to the comfort, you know, we don't even get the areas that many medication because we need to keep a certain stock for ourselves and we don't wanna overstock it and, you know, disappear on it because it's harder to track.
Can I hit on one thing on the last slide for them real quick?
Yeah, right.
Sorry. All right, and I know it's gonna be weird. Like, how the fuck do you remember this, right? So that May 1st date, you should have remembered seeing that day before. May 1st is the day that open season opens for TRICARE. It's the same exact date, but I've seen them ask on when they conduct that inventory. So it's gonna be biennial, on or about May 1st of odd numbered years, right? Biennial, so twice a year, on or about May 1st of odd number years. Okay, and remember that May 1st, just think that's the exact same day that open season starts for TRICARE.
For this, one of the most important things is that you can't just verify your own audits. That's why we get outside personnel, and so we should verify by 2 people. There shouldn't be a single person verifying their audit. I did the audit by myself, everything's good to go. It requires more than 1 person because it keeps us honest, you know. It removes the whole, hey, this person did exactly with the inventory, but something went missing. That's why we need the second person to verify that. We can just take just 1 person word for it. So sometimes CSIB is normally 2 to 3 bodies. If they're doing the whole inspection, I normally get around 6 or 7 members inspecting my vault at the same time because some of them come to learn how to do it. Some of them it's just easier to 1 person count, the other person writes. So, but it's always gonna have more than 1 person. Because if one of us just walks into your space, hey, I need to inspect something, we're probably in the wrong. You know, so we have that second body with you in order to do these inspections. And for us, for the custodians, we have to inspect them at least weekly. So every Friday, my pharmacist will actually sit down both outpatient and inpatient and count my entire C2 safe in order to make sure we're actually removing all the discrepancies and we catch those. If we have any discrepancies, unfortunately, we can't leave the pharmacy until we find the stuff. So very bad day for us, and that's what we try to keep away from actually doing discrepancies. But make sure if you guys understand how often do they check our discrepancies, we have to at least do an inventory account weekly. You can count stuff every morning because you should be counting the stuff at turnover too, but the final verification happens on a weekly basis. Again, more on the CSIB, you know, these are the members that should be on the CSIB. So our members are gonna be coming on a quarterly basis, and they're basically the only ones authorized to come in, and they have to be approved by the CO. So they actually appointed members of this. You know, there's a little more stuff will come into place because there's tests that you have to take and you have to get appointed. But mostly it has to compose of E7 to E9, a GS7 and above, are the ones who are part of CSIB. So you never see, basically you have to have a commission officer over there as well. So you're never gonna see an H1 part of CSIB when it comes to inspections.
And then I'll most definitely be on the test. The commissioned officer part, the quarterly, and E7 and above.
Alright, so this is basically when we deal with any kind of theft or deterioration, there's some drugs that we actually have to dispose of, so we have to destroy them. But in order for us to destroy it, we have to file a report, so there's a DEA Form 106. We provide a copy for the DEA, one copy to the Human Specialty Leader, the MTF region, and the nearest representative for MCIS in order for us to be able to identify theft or deterioration of the actual med. We can't just throw something away and pretend, oh, this medication is broken. We have to keep even the broken pieces in order for us to put it for destruction. So understand that you have to prepare the original and 3 copies of it. So that's the answer for that if you ever see that question like that on the test.
And remember, this is probably one of the only, I think there's only one other one out of all your bibs, DEA form that you are going to see. So it should be able to recognize it. DEA Form 106 for report of theft.
Another thing that's important for this, we cannot destroy anything without the CO's approval. So us as pharmacy, we can't just be, hey, we're gonna destroy it tomorrow. The CO actually has to sign on this for us to destroy it, and one of the at least the CSIB members have to be present at the time of destruction. So we can't just be like, hey, let's throw this into the incinerator tomorrow. So the CO has to have knowledge that what we're doing and exactly what's gonna happen when it comes to that. Pharmacy does not determine that, as determined by the CO. Over here is just a breakdown of the forms that we use. So basically, they're NAVMED 6710-4. We use that on a daily basis because basically that's how we log down what we were writing, and that's how we keep our inventory. Now that everything's kind of going electronic, they're trying to phase away from that. But currently, we use this form and we change it every 24 hours to make sure we keep up with the actual dates to see what was filled that day. So if I get an audit, I know exactly what that medication was filled. Then we have basically the 6710-1. That's just a controlled substance book. It's basically where I put all my forms that are for the 24 hours. They just go on that book for us to have it for audits. So it's not something you have to memorize. The only one that I would recommend knowing is the 6710-4, because that's a controlled substances for 24 hours. That's the most common one that I've seen on tests when it comes to test taking. The 6710-5 is basically the perpetual inventory and all of that we have to keep. That's just an additional form for us when we actually do our big count on Fridays. The 6570-2 is basically our compounding on pre-pilot. That's just a regular sheet. You don't see it as often. That's something for us that we use internally. That's just basically we write all the unit doses and all the stuff that we do for IVs. That's the form. The DD-1289 is what we keep beating on, the regular hard copy prescription. Remember, it's just for single use. The 6710-6, that's the poly prescription. That's the one for more than one prescription to be written on it. And the last form is basically the DEA form of 106, which is the one that we use to report tests on controlled substances. Like I mentioned at the beginning of this, we account for 2 years worth of records. So if they ask you any questions about how often do the records in pharmacy need to be, how old can the prescriptions be, we hold it for 2 years. So that's one of the things that you have to be able to answer on a question. It has to be at least 2 years worth of prescriptions in order for us to be able to be in compliance. And like I mentioned before, if we don't have a pharmacist, the responsibility falls into a commission officer. Now, more likely, sometimes it's a senior medical officer, but it doesn't necessarily have to be a medical officer when it comes to being the commission officer in charge of controlled substances. That's all I have. Sorry the PowerPoint is so long. So.
I have a word of advice for y'all if you want to do this. I talked about at the beginning that it helped me, and it used to throw me off on the test. You see 2 years a crap ton of times through all your bibs. You sometimes see 3 years, you sometimes see 5 years. What I would do, and it might sound kind of crazy, but I would at least group everything I know that falls into a 2-year category, everything that I know that falls into a 3, everything I know that falls into a 5. so I'm not going to get mixed up on the test. I have a way to group them together to where I'm not having to think in my head when I see this, is this 2, 3, or 4 years or 5 on how long I'm keeping this. Okay?